So thank you very much, everyone. By way of introduction, I'm Dr. Dylan Powell. I'm a physiotherapist and lecturer in public health innovation at the University of Stirling. The topic we're going to be exploring is the evolving landscape of MTBI assessment in concussion. And I just wanted to add, so I'm a physiotherapist. My PhD was in concussion, and I spent a number of years in industry. So really interested, a little bit like Miriam was saying, from a couple of different lenses. Firstly, the patient care. Two, what we do as physios. And three, actually, how does this benefit the system, the health system as a whole? So we're not going to be able to cover everything. It's clearly a really large and broad topic, but we're going to split this into 4 parts. So why MTBI matters, how it operates in a non-sporting setting, and then how it typically operates in the kind of low-resource sports setting. And then looking ahead to the future, what are some of the shared challenges and opportunities that we have in concussion assessment? Delighted Miriam's able to join us for the panel Q&A, but we also have David, Tom, and Stephanie who've all contributed to this talk. So just wanted to acknowledge that there's 3 of us speaking today, but there's been a larger team contributing here. And to align on what concussion is, or MTBI, so we know it's caused by an impact to the head or neck, typically direct or indirect forces. This leads to a brain injury, which is a complex pathophysiological process. The main take-home is it causes lots of different impairments. So we know it's a complex injury, and this has implications for the way that we might assess and treat. What's the significance of head injuries? Well, we also know that there's around 1.4 million people attending A&E every year with head injuries. That ranges from mild traumatic brain injury all the way up to severe MTBI. There's real concern about the short and long-term impacts of sporting MTBI, but as Miriam was outlining, there's a clear socioeconomic cost of these types of injuries for patients, families, but also actually economically. But I think the take-home, and I think there's probably broad agreement on this, is that the way we assess and identify head injuries is quite challenging. So we've made a lot of progress in certain areas, but there's still a lot of room to improve. And as I said at the start, this is a real broad spectrum. So we have sports head injuries, we have RTAs, road traffic accidents, and we have falls in the elderly. So often when I say I've done a PhD in concussion, people start talking about football and rugby, and absolutely, you know, former rugby player, love looking at that. But actually, if you look at proportion of most people going to A&E with head injuries, it's not people from sport. So again, part of the purpose of this talk is to, yes, let's look at sport, but also open up the conversation to non-sporting MTBI as well. And as I mentioned, the way that we assess, there's some alignment there, but actually there's some challenges in how we might begin to harmonize these assessment approaches. So I'm delighted to welcome our first speaker, which is Dr. David Hamilton, who's a physiotherapist and reader at Glasgow Caledonian University.
Good morning, everyone. Thank you, Dylan. Yeah, so I've been tasked with giving a very top-level look at the sort of non-sporting concussion landscape. I'm coming at this from a sort of my 20 years of more MSK focus and more recently moving into concussion research. So I'm not a neurotrauma expert. Some of you in the room will likely know far more about that. This is much more about the bigger picture context, and I'd like you to keep some of these maybe messages in mind when Tom's speaking about the sort of sport and community context later on. So, as Dylan's mentioned already, concussion and traumatic brain injury is quite a big deal. This is the best data that we could find. A recent Lancet Neurology Commission reports 55 million people affected per year internationally. But if Dylan's right that there's 1.4 million people reporting to A&E with a head injury in the UK every year, that's almost certainly a vast underestimate. And there's a significant cost. We're dividing brain injury into sort of 2 main bits here. The vast majority we're going to classify as mild, sort of MTBI or concussion. We often use these terms interchangeably, possibly correctly, possibly not. And the 10% that's much more significant that would be beneficiaries of the rehabilitation centre and the expertise that Miriam was describing before. So I'm going to give a couple of key messages, and really my take-homes in the last couple of years starting to move into sort of concussion research field. That concussion, mild traumatic brain injury, is a clinical diagnosis. We have lots of fancy tools and kits that we can talk about later if people desire. But actually, frequently medics, but any qualified, trained healthcare professional, makes a clinical diagnosis based on a neuroclinical exam. This is a hands-on clinical episode where a diagnosis is made. Imaging is very useful. Imaging is often used in the A&E setting, but really to quantify the clinical exam. We do have adjuncts. We have neuropsychological tests, things that you'll be hearing more about later on, where we can measure memory and visual acuity, etc. But these are adjuncts. We also have ever-expanding plethora of biomarkers, blood biomarkers, salivary biomarkers. You'll be aware of the explosion in proteomics, metabolomics, etc. There's loads of tests, inflammatory cascade markers of. These are useful adjuncts, but they don't actually form part of that core main clinical exam, which is still literally based on the neurobiology. The next key reflection for me is that mild TBI is a bit of a misnomer. Some cases, we're talking about a transient blow and a knock and people recover quite quickly, but the classification of mild TBI is presentation at A&E with a GCS of over 13. So you can have some quite significant symptomology within the diagnosis of mild TBI. The other significant learning for me in this field was that people don't just recover quickly. Some do, of course, but there's large cohort studies with thousands of participants, thousands of patients with mild brain injuries that report ongoing symptomology at a year. In fact, close to 50% of people in these large 1,000-people studies are reporting some degree of symptomology at a year. They're frequently back at work, but they're not symptom-free. I think that was a very key, important lesson for us in the work that we've started to be doing. Just to hone in on that variable recovery nature, the majority of people with a mild traumatic brain injury are that simple fall, that rugby injury. It's a transient injury. If there's any unconsciousness, it's fleeting. There's very little amnesia. GCS is usually 15. But even in that person, that's not always a quick, rapid recovery. The vast majority of people are recovering within 12 weeks. 6 to 12 weeks is the accepted time frame. But as I've just said, many have ongoing symptoms. 90% of people that are diagnosed with a mild traumatic brain injury will be back at work and back as normal, quote unquote, within a year. But as we've just seen, 50% will still be reporting some mild symptomology in that timeline too. And then, of course, if 90% recover quite well, 10% don't. So 10% of people with a mild traumatic brain injury have ongoing significant symptomology at a year that requires further input, and quite significant further input at that point, because it's just not resolving. In terms of treatment, it is as we expect. For the most mild cases, it's cognitive rest, it's taking time out of work, time out of sport if that's part of it, or school quite frequently as well. Gentle exercise or active recovery is a key, and obviously symptomatic pain relief. This is for the 90%. For the other 10%, we're talking about a much more significant intervention, much more along the lines of the centre you were just hearing about, where we'd expect the full gambit of the MDT to get involved: psychological intervention, rehabilitation intervention, and pharmacological intervention. So just a few quick, brief summary points to bear in mind as you're hearing about the sort of wider community landscape. Mild TBI doesn't necessarily mean minor symptoms. Most people recover relatively quickly, but when I say quickly, I'm meaning 6 to 12 weeks with significant time out of activity in that time frame. That obviously requires some patience from the patient's perspective. And that 10% of even the most mild brain injuries do not resolve quickly at all and have ongoing problems. And if there's over 1 million people presenting every year, 10% of 1 million is still a very big number. Thanks very much.
Brilliant, thanks, David. So, yeah, absolutely. I think it's a really interesting topic. We focused there on non-sporting MTBI, but there's lots of shared overlap, as David mentioned. I think the other interesting take-home for me there is that our ability to measure things is maybe limited at the moment. So actually our understanding of things, again, is limited. So those numbers there of 10%, 90%, it's actually quite a complicated picture. Okay, so delighted to introduce our next speaker, who's Tom McKeever, a physiotherapist and lecturer at Napier University. Over to you, Tom.
Thanks very much for the opportunity to speak today, and also thanks to Dylan for the introductions. I seem to have missed a memo in digital innovation because I've got paper notes with me here today, so please do excuse me. So as Dylan's mentioned, my name's Tom McKeever. I'm a lecturer, a physiotherapist and a PhD candidate as well at the Edinburgh Napier University. My PhD essentially is on looking at the management pathway of the concussed youth athlete in Scotland, and today I'll be focusing on concussion in the youth athlete, really around the premise of grassroots sports management, the state of play in non-elite care. So as we've discussed, there is a high incidence and emerging evidence that concussions and repetitive head injuries or head impacts can be harmful to health. Currently, our reference standard in terms of assessment is a pen and paper exercise and form, the SCAT-6, the Standard Sports Concussion Assessment Tool version 6, which essentially is a measure of cognitive and vestibular performance and is taken at baseline, or recommended to be taken at baseline for all athletes. The idea being that following a suspected concussive episode, there's a retest of this measure, and we have some subjective and mildly objective data to tell us whether there's been any change and whether we suspect a concussion. However, it is important to note that there is no true objective gold standard measure or gold standard for concussion diagnostics. So, keen to focus here as to what happens next following suspected injury for a concussed youth athlete. At the moment, we primarily rely on the messaging, if in doubt, sit them out. This requires coaches, parents and sideline medical staff to recognise and remove following suspected injury. And consensus group advice is to stand youth athletes down from sport from 14 days, known as our kind of minimum rest period, and then commence a graded return to play. I think it's important just to note here what David said about sort of typical recovery trajectories being a lot longer than that. So at 14 days, we're returning our youth athletes back to sport. Graded return to play for the young athletes essentially should be supported and carefully monitored through this stage, and symptom exacerbation managed swiftly and effectively. However, this all requires resource, and resource which most community sports and settings do not have. The reality of the field, or the reality in community youth sports, is that resource is limited generally, certainly in terms of medical staff provision and team provision. The table that we have here highlights which medical professionals are readily available for the professional and amateur game. However, most certainly in most youth community sports settings, none, if any of these resources will be present at all. Therefore, we rely on the knowledge and experience of bystanders in managing these situations, and if we're lucky, some of these members of the sideline group are first aid trained. It's important, I think, to touch on the areas of progress that have been made in this field. Certainly improved awareness or improving awareness. Concussion education initiatives have improved and popped up, and there is an increasing research base on concussion. And I believe an improving and evolving sports injury management culture. I think one example of good sports injury messaging is having the if in doubt, sit them out messaging on rugby kits and school-aged players. Where I see the areas for opportunity being, essentially early data suggests that medical students lack the necessary confidence, knowledge and skills to identify and manage concussion, a really interesting study from Scotland that's worth looking at. It would be hypothesised that other HCP students and practitioners may also feel the same. The development of clinical competencies and upskilling clinicians could be the answer to improved healthcare workforce management of youth concussion. However, this would only impact those who attend for care. Innovative approaches are required in poorly resourced community game settings and will most likely revolve around coach, parent and player education. Another avenue of opportunity could be providing AHP resource to community settings for large-scale concussion baseline testing and management pathway services. And finally, emerging technologies such as medical biomarkers, as David's mentioned, and digital technologies may help negate the resource challenge and provide youth athletes with better care faster. Thank you for listening.
Fantastic. So thanks, Tom, and completely agree. We've had lots of areas of progress. So we want to make that point that the education, the awareness has improved dramatically. But I think the points that David mentioned still ring true in that we're still probably very early on in our understanding of disease progression, mechanism of injury, and how we might begin to treat. So, as we've discussed, there's certainly similarities in the way that we might manage a non-sporting MTBI and a sporting concussion, but again, there's probably slight variation in the expected timelines of recovery, and also maybe the competencies you might have in an NHS setting versus someone who is playing their rugby game on a Sunday and might be doing more self-management and relying on those pathways that Tom mentioned. And again, the timelines of those return to play, certainly over the last 5 to 10 years, have changed and vary. There's definitely greater alignment between the UK in there, but for many years, for myself working across England and Scotland, it might be the case if someone had a concussion in Scotland or were playing for a Scottish team, they might actually return quicker than in England. So again, those subtleties are beginning to get ironed out, and there has been improvement there. But where are we headed? So the next part of the talk is looking ahead. A little bit like Miriam was talking about, we know we're making great strides in certain areas, but what are the opportunities? So just really quickly, for me, the challenges in the way that we assess are broken into two parts. We hope that someone might have this typical disease trajectory or kind of return to play. Their symptoms might increase, and then there's that smooth recovery after. My experience is it's never like that. You have one day that's fantastic, another day that's terrible. So when we're using these SCAT5 symptom resolution tools, that makes the confidence in return to play really difficult for the player. The other challenge is the episodic nature of how we conduct assessments as physios. Often it's a 30-minute appointment or a 45-minute appointment, and we might not be able to see them every day, certainly in the low-resource settings. A little bit different maybe in the rehab centers, but certainly in your day-to-day physio practice, it's more like this. So two key issues. Difficult to track that return to play and progression, and then having that certainty when maybe it's safe or someone's recovered. So really, from my side, we're probably at the tip of the iceberg in the way that we assess concussion and head injuries. We use subjective tests, and we get subjective outcomes. So really, to move to the next level, we need to go below the surface and look at things in a more objective way, harness the tools at our disposal, and begin to augment our assessment. Not replace, but augment and build on. And for me, that starts by looking at the multimodal nature of concussion. And I wanted to highlight, so my PhD was jointly in computer science. I'm not completely computer science coding expert, but just wanted to highlight, if we think maybe our physio assessment, we might get 15, maybe 10, 15 minutes of good data capture. And we might get some good, maybe 1 or 2 outcomes from that. If we harness continuous data from wearables, in 15 minutes, we're looking at around 90,000 data points. In 24 hours, we're looking at over 8 million data points. And clearly, at the moment, not all those data points are either going to be useful or we don't understand them. But it's a step change in the ability for us to collect data. So actually, we're probably entering into a different phase in the types of skills we need as physios. How are we going to make sense of these types of data points? Another challenge, which I think has been common across a lot of talks at the CSP, is how we begin to communicate these new and emerging areas to patients. And the way that I rely on is we probably, as physios, tend to look at these little snapshots. And for me, that's like watching the trailer. And if we really want to get a better picture of what's going on with a patient in concussion, in Parkinson's disease, in any other part of healthcare, we need to shift to looking at the whole movie. So again, I think the communication and the terminology we use with patients is also really important. A key part of that is how we begin to integrate data sources. This is a paper that I published earlier in the year, which is looking at how we use digital biomarkers in our holistic assessment of different injuries. This isn't specific to concussion, but actually just provides a little bit of an easy read in some ways compared to some of the other literature out there. So looking ahead and building upon some of the points that Tom and David had made, we need to look at how we can explore the integration of these novel technologies, not replacing but augmenting our current practice. If we begin to also take a step back and look at MTBI, as I said, in the kind of broader spectrum of brain health, not just seeing concussion and non-sporting MTBI as these different parts, but actually seeing it as a bit of a spectrum. Talks about technology and data, and I think another real important part is the diversity of the research that we're conducting. So we know there's emerging evidence around maybe how males and females respond differently to concussion, or how we might need to augment our assessment or change our assessment. So for me, that's another key factor looking ahead. And as Tom excellently put, the kind of skills that the MDT need and how we begin to integrate. And we can do that in high resource settings very well, but actually how do we do that, and how do we begin to scale that down into areas where there might not be the same level of resource? So thank you very much. I think we've got time for questions. Fantastic, great. Okay, yeah, fantastic.
Thank you. Sorry for jumping ahead on my question. Thank you for the talks. That's absolutely fantastic. The National Rehab Centre, I don't know if this question perhaps goes to yourself, Miriam, but do you think there'll be scope within the centre for kind of clinical academic roles for therapists, or do you think it'll kind of keep them separate streams but working together? Asking for a friend.
So we have some clinical academic roles in our workforce plan, and that's entirely the point of bringing that research and clinical function together to promote exactly that. We actually want everybody to be a researcher in the NRC as well as a clinician. That would be my absolute ideal. But yeah, either combining it with that teaching and training position or as a researcher, then absolutely.
Thank you. That's very exciting. I'll pass that on to...
Hi, thank you. That was really interesting. I'm Lisa Knight. I'm a neurophysio, and in recent couple of years, I've seen quite a few post-concussion patients. And my understanding is that it's primarily a functional neurological disorder. Have you got comments on that, and at what point do you delineate it as post-concussion syndrome? And I just would be interested in your thoughts.
Yeah, no, it's a really, really good point. I think I would certainly look to some of the evidence in the US. So we work quite closely with Oregon Health State University as part of my PhD. And their data sets are looking at that non-sporting population. So probably, I think my narrative is that we can get a lot more insights from the non-sporting side who have been probably researching it in a practice perspective, whereas the sports-related concussion, again, has taken a slightly different angle from it. I'd say, like most brain injuries, it's very patient-dependent. The other, I guess, misconception, which I know you'll be familiar, is often people say they've gone to A&E because they've been concussed because they got knocked out. And again, it's just getting across to the patient that the reason they're getting a scan is to rule out a more severe injury. The imaging isn't for the concussion, it's to rule out a more severe injury. So I think there's probably an evidence gap there as well. But to answer your question, I think it's complex, but I can signpost the resources that I certainly use if that's helpful.
Yes, thank you. Yeah, I mean, they certainly have been complex to treat.
Yeah.
And there have, to me, that FND label has fitted quite well with the patients that I've seen, which is just a handful, but I think it's a complex area, and there's sort of post-traumatic elements to it as well sometimes, the mechanism of injury.
Yeah, absolutely. The other thing actually Tom and I were talking about yesterday was, certainly from my perspective, we look at concussion and we might ask if you had a concussion before. We don't really ask many questions about earlier life. So if we look at other brain health conditions, we're often a lot better asking early years developmental side of things. So from my side, that could be an interesting area to join up. So I would agree with you, complex. Yeah.
Thank you.
I just wanted to jump in as well quickly with regards to that, and you can tell I'm an eager PhD student jumping to answer any questions, but I suppose this really has been my world over the last 2 years. I think that with the youths, it's interesting because a lot of the primary data that drives the decision-making around the sort of guidance for return to sport and return to activity, we've moved away from this old-fashioned model of lying in a dark room for a long time, because actually we're finding that outcomes are much worse, and actually the evidence suggests starting sort of low level, mild to moderate activity levels earlier on, vigorous activity not so much, because it disrupts with the kind of energy crisis and that resolving process sort of from a pathophysiological point of view early on. But I think that there's definitely something to be said around taking kids out of school for too long and not allowing them to sort of reintegrate with their peers. So I think there's also a sort of psychological element there, whereby if you take somebody, say you had a concussion, sit them out for a long period of time away from their peers, away from learning, there's almost potentially a little bit of, some challenges about reintegrating into school, sport, etc., at that really important developmental age and part of life as well. So I think that there's risks, but over-treating almost in a way, there's that happy medium that we need to find.
Hello, I'm Caroline. I'm one of the major trauma advanced practitioners at Salford Royal. So 2 questions. Miriam, please can I come and visit that facility when it opens? It looks fantastic.
Yes, you're very welcome.
We've just opened a new hospital as part of the new hospital scheme, and we have no rehab facility in that. So it's a fantastic facility, but it's very acute. So I'd love to see what you guys are getting up to, even though my boss wouldn't be too happy if I got a new job. So, and then Dylan, I suppose the question to you is, and it leads on that very nicely from what you were just saying, we often see a lot of people at the front door that do get a CT scan and they get turned around as no traumatic brain injury. My concern is that we miss quite a lot of the diffuse axonal injuries, and that's because we're not MR scanning a lot of these patients. Now, some of them are safety netted because they get to come onto the ward, and we then pick up those subtle cognitive deficits or the kind of physical deficits as well. But it's the ones that get turned around in ED, and I wonder whether we are missing those patients that then come on to be those, what you've just described as FND. I suppose, is that maybe worth looking at maybe changing that imaging modality a little bit in A&E and moving more towards how they do it in America, where they do a lot more MR scanning. And I suppose I wonder how many patients we are missing from getting the correct diagnosis, and what your opinion is on that. Sorry, I've just taught loads there, sorry.
No, not at all. It really, and actually, Ash had mentioned to have a conversation, so we'd love to continue the conversation about it. Certainly, from my side, I agree. There's definitely that maybe missing middle who aren't severe enough, but are severe enough to go and go to hospital. In terms of imaging, again, I would agree with you. The evidence would be we might we want to scan for something more severe. It's all that whole question about access and cost, which is a challenge. Certainly from my perspective, a lot of the work I've done is in that sub-elite. So the other thing we probably should mention is we're talking about non-professional sports. We weren't have time to begin talking about that. But I think it's a really important question, as you said, because it's how do we begin to improve our understanding of just concussion? And then secondly, what's the best and optimal management pathway? Why I mentioned that kind of trailer versus the movie is that I think it does apply to a lot of anecdotal and professional experiences, that you might spend 3-4 hours waiting in A&E, and then you get kind of a pen and paper card to say, watch out for these red flags. And what does that actually mean to a 15-year-old, 16-year-old kid? And again, if we go through those pathways that Tom was talking about, it's really, really hard to use symptoms as your main threshold for return to play, because in other injuries, you often have that 5 out of 10 scale for kind of working through symptoms, but in brain health, it's more tricky to know where that line is. So I think probably for me, we're just still really early on in our understanding. So I would welcome more multimodal and a little bit more in-depth assessment.
I'm just going to jump in quickly because it kind of relates to both questions. I think if we think about the initial presentation, we can make a clinical diagnosis of what's happened, but it won't stay like that. Increasing use of MR technology is potentially useful, certainly in ruling out bad things there and then. But the positive predictive value, even of the most fancy imaging, isn't actually that great for long-term sequelae. And the bigger issue, thinking as well about the functional classification, is most people don't go there, but some do. So how do we work out those early on that are not going to have that shorter transient recovery, but are going to require the much more significant input? I think we do quite a good job in A&E working out who's going to bleed, who needs to get in for some intervention, etc. But then the more subtle neurological features that are effectively still a clinical diagnosis requires the input of clinicians and the clinicians over time. And I think that's the bigger worry away from secondary care, where we have people with fantastic clinical skills that can pick up these subtle differences and know that, oh, something's not quite right here, I'm going to do something else. That just doesn't exist at all in the community. People don't have the skills. And if it's quite subtle, potentially to an experienced physio, it's not obvious at all to a loosely trained layperson. So if we're missing things in secondary care, we're missing a bucket load of things away from secondary care. I think that's the really important factor behind all this.
Fantastic. I'm getting waved at someone to say stop.
We've just got one question
Okay.
from the online delegates, if that's okay, guys.
Yeah.
And actually it's from Anne-Marie online, just follows really, really nicely on from what you were saying about potentially problems in primary care and things being up in secondary care. So this team's had some debate in relation to unwitnessed falls in people living with frailty where head injury can't be excluded, but the costs associated with transporting to hospital via ambulance for CT versus that patient just remaining at home, and the ethical question around the benefits of that when the majority of people living at home with frailty don't have that follow-up with sort of neurosurgical specialists or a specialist. So thoughts on that and whether that's something that you are planning to explore in your research. Nice meaty one to finish.
Yeah, I can start on that one. I think, we haven't actually talked much about the kind of elderly population, but I would agree, you get your standard orthopedic patients and head injuries is a likely distracting injury potentially as well. I think the brain health area is super complex. I do a bit of work with a company in Scotland that is in Alzheimer's and dementia, and again, that shift to looking at things across the life course. So I think it's tricky to have an exact pathway, and the other presentations we've had this yesterday around multimorbidity, it's unlikely someone's going to just have a problem with their head. There's going to be other systems that are challenging. So I don't know if that answers the question exactly, but I think I'd probably say with concussion, we're not quite there in our understanding to have these nice, neat, personalized pathways just yet. We're probably still in that early stage of working with the evidence we've got, but it gets more complicated with sport and non-sport. I don't know if anyone else has got.
So can I just come in there as well? So I think this is really important, and this is all around the interface between primary and secondary care. One opportunity around this is with the community diagnostic hub, so that it's much easier for people to access that imaging and radiology at that acute moment. But it's how then we build those pathways around. It's not just about giving a leaflet in A&E and asking somebody to look for their own red flags. That's not sufficient enough, because we are missing a huge population, I think, around this, with significant long-term outcomes, which will absolutely impact into how they can go back to work and do all of the other things that they once used to do. And my experience of concussion is exactly that, Dylan. It's like, a different experience every day. So I think there's that bit in the middle for me around how we educate the wider population, and I think it is the wider population around recognising the significance of concussion and the impact of that on a long-term basis, and actually getting that diagnosis really early. But when you've got that diagnosis, and Canada do this really well as well, don't they? There's then a system, you're in a pathway, you're there somewhere, and that's where a lot of people are falling out at the moment, I think.
I'd just quickly jump in and say as well, I think that there's a lot of parallels between the youth and the elderly in regards that there's a lot of other symptom drivers, more complex, obviously, elderly patients, lots of underlying issues that may be driving cognitive change or symptomatology change as well. Similarly with youths, and there's other drivers for that as well, but certainly still more challenging populations to assess for concussion. I think where I'm finding that there's people that are well placed in the youth area, like teachers and parents, coaches. There might be people well placed within elderly communities and sort of carers, etc., that are able to pick up on those subtleties as well when they're visiting patients potentially post-fall and reviewing something in terms of like a post kind of traumatic response. But I think the key thing really is around, being a physiotherapy conference here, focusing again on how we can look forwards to educate the physiotherapy students and population. It's something that sits kind of out with any traditional sort of curriculum, something we're starting to introduce, certainly at the university I work at, and I would certainly like to roll that out going forward. So,
sorry, we need to bring this session to a close now. Thanks so much.
Sorry, we're getting...
No, that's all right, don't worry.
Waved at.
Thanks very much, everyone.
Okay.
Blah, blah, blah.